Hello, everybody, and welcome to the Hirschberg Foundation for Pancreatic Cancer Research webinar, Pancreatic Cancer, Our Goals and How to Achieve Them. My name is Amy Reese, and I am the Patient and Family Support Coordinator for the Foundation. First, I'd like to acknowledge all of our wonderful sponsors who help make these webinars possible, including Novacure and FibroGen. Today, we welcome back Dr. William Isacoff to our Patient and Family webinar series. Last year on July 31st, Dr. Isacoff presented Chemotherapy for Pancreatic Cancer Patients, Less is More. With over 7,500 views to date, it has been one of our most watched, and many people reached out to me afterwards to get a copy of his metronomic manuscript for dosing. Known worldwide as a renowned oncologist and for thinking outside the box, he will be transitioning this year from private practice to focus on research in the field of pancreatic cancer. We will always be grateful for his dedication and innovation and look forward to his future successes. Thank you, Dr. Isacoff, for joining us today.
Well, thank you for having me. Aren't we going to have a hello from Aggie?
I'm going to thank you at the end.
Okay. Well, I want to thank Aggie Hirschberg, the Hirschberg family, and the Hirschberg Foundation, not only for making these webinars happen, but for all the work they've done for over 20 years to help patients, to help their families, and to also help raise money to support pancreatic cancer research, not only at UCLA, but also through young career development awards for young investigators all throughout the country. So a big round of applause for Aggie, the Hirschberg Foundation, and everyone within the foundation that make these things happen. Thank you. Are we ready to start?
We're ready.
Yes. Okay. Okay. So most of the foundations that I am aware of have for 20 years raised money to support science to make the outcome for pancreatic cancer better. And by outcome, we really care about prolonging survival. I think so far, we've not really achieved our goals. And there are a few reasons why, which we'll talk about today. Can we have the first slide? A brief summary. Pancreatic cancer in 2021, the incidence in the United States will be roughly 60,000 new cases. It used to be the fourth leading cause of cancer-related mortality, and today it's the second leading cause of cancer-related mortality. Unfortunately, only 20% of patients that are newly diagnosed are diagnosed at an early stage, amenable for surgical resection and a chance to cure. 80% have advanced disease. About 40% have locally advanced, which means it is infiltrating a local structure next to the pancreas, whether it be nerves, usually blood vessels, or adjacent organs, making it unresectable from a technical point of view, but no evidence of metastases. And 40% will have recognized metastatic involvement of distant organs. The most common would be the liver, then intra-abdominal carcinomatosis, meaning other places in the abdomen, lymph nodes, and eventually possibly lung or pleural metastases. The result being that 80% will require chemotherapy for advanced unresectable pancreatic cancer at time of diagnosis. The next slide. Okay. Actually, I'm seeing some images here. Can I somehow, oops. Now I lost everything. Okay. I lost my image. I lost my slides. Can you,
Is this
how do I get my slides?
combination?
Say that again.
Are you on combination chemotherapy slide?
Yeah, yeah, it's in the corner. I can't see it though. Wait.
We see it
Well,
quite clearly.
why don't you read it and then
Combination chemotherapy is more
Yeah.
effective than single agent.
can you fix this? We're gonna have someone go ahead. Okay, got it back. Is there a slide before this?
Yes. There was.
Okay, background. Okay. As I said before, most patients with pancreatic cancer have metastatic disease. Unfortunately, the prognosis for those patients with advanced disease has not improved really in 20 years. Oncologists, basically, if they see an improvement in 2, 3, or 4 months, most of the time they get excited. If you show the data to patients, my sense is they wouldn't be so excited. For those patients with metastatic cancer, using standard of care, the 2-year survival is usually under 10%. Standard of care today is combination chemotherapy. The combination chemotherapy is traditionally used at what we call the maximally tolerated dose. Patients go through a phase 1, phase 2, and eventually a phase 3 trial. Phase 2 trials try to establish what we call maximally tolerated dose. I spoke about it last year that the tradition is to get the highest possible dose for the patient, thinking that higher doses kill more cancer. That's not true. Only in one disease, and that would be acute leukemia or the other hematologic malignancies. So for hematologic malignancies, higher doses achieve better survival. Higher doses for solid tumors in adults will not result in a higher cell kill and will not reflect in an overall survival benefit. Next slide. Okay. Here are the common regimens that are currently used to treat patients with pancreatic cancer. All of these have been tested in phase 3 trials and have demonstrated that gemcitabine and Abraxane offer a better overall survival than single agent gemcitabine. Gemcitabine, Abraxane, and cisplatin also have demonstrated better survival than single agent gemcitabine. And FOLFIRINOX, which are 4 drugs, 5-fluorouracil given as a 48-hour infusion, and this is given in conjunction with calcium leucovorin, irinotecan, and oxaliplatin when compared to gemcitabine. had a statistically significant improvement in overall survival. All of these regimens are used near or at their maximally tolerated doses, and all of these regimens, in essence, are recommended by the National Comprehensive Cancer Network. So this is basically it. The most active and felt to be the most effective treatments for advanced disease. Next slide. If you poll a lot of oncologists, their preference would be using FOLFIRINOX, especially if patients are young, that is under the age of 65, and have a good performance status. Their preference, as I said, is overwhelming FOLFIRINOX. But look at the data. This is the data that was published from their pivotal trial that got it approved by the NCCN, by ASCO, and by the FDA. Response rates of 31.6%. So the majority of patients have no benefit from FOLFIRINOX. The overall median survival is 11 months. The 2-year survival is less than 10%. And the duration of time on treatment is a median of 4 months. So let's think this through rationally. Patients with advanced pancreatic cancer have a life-threatening disease. You're going to put them on a regimen for which 50% of the patients can only tolerate it for 4 months. I'm not sure that's too rational. The other aspect is a lot of times oncologists like to say that they're treating patients with cancer as a chronic disease. Well, if you're treating pancreatic cancer as a chronic disease, then you should want to treat them for more than 4 months. So designing a regimen that half the patients are off in a median of 4 months, I don't think is a very rational approach. The survival times in months, you can see that at 18 months, less than 20% are alive, and at 24 months, less than 10%. So to me, this is not effective therapy. To me, this is treatment that, when used according to the guidelines, offers a lot of toxicity and I think limited benefit. Next slide. Next slide. Okay. So what happens when you use chemotherapeutic agents at the maximally tolerated dose? The result is you need to allow the patient to recover from his first cycle of treatment and subsequent cycles of treatment. The result is that there is a long or prolonged drug-free period. Maximally tolerated doses limit the number of drugs that we can use. I'd like to use 6 drugs, but if you use them at the maximally tolerated dose, 6 drugs will put everyone in the hospital. You need a long time between each dose. I always used to say to patients that cancer loves vacations. The longer they are on a chemotherapy vacation, the more they develop resistance, not only through mutations, but by amplifying the genes that are the targets of the chemotherapy. Using drugs at the maximally tolerated dose requires growth factors between 50 and 100% of the patient. Growth factors, I'm sure you are all aware, are either those factors that stimulate the bone marrow to make red cells, or stimulate the bone marrow to make white cells. Some protocols require growth factors to be administered with each cycle. What you may not be aware of, one dose of Neulasta in some hospitals costs more than $5,000 a dose. So it certainly adds to the cost, but doesn't add much to the benefits. 30% of patients on FOLFIRINOX have required hospitalizations. Again, diminishing quality of life and increasing overall costs. These high-dose regimens are certainly not patient-friendly. They also promote angiogenesis. What do I mean by that? When you give a growth factor, well, first of all, a long interval between doses allows bone marrows to recover. As bone marrows recover, they not only release more red cells, white cells, and platelets, but they also release more endothelial progenitor cells. These cells are vascular precursors. They go to the cancer and they help the cancer make new blood vessels, angiogenesis, neovascularization. So on one hand, you're trying to kill the cancer. Sorry. If I can find my phone, I'll shut it off. Okay. So on one hand, you're trying to kill cancer with the cytotoxic effects of the drugs, but on the other hand, you're trying to help it grow by allowing the cancer to make new blood vessels. Again, not a very rational approach. So the long intervals rebound the marrow. The marrow is kicking out these endothelial cells, hence angiogenesis. When you use growth factors, not only are they kicking out the white cell precursors, but they also kick out the endothelial precursors, again, promoting angiogenesis. So none of this, to me, is a very rational approach. Next slide. So for FOLFIRINOX, I went over this. Less than a 35% response rate, a 1-year survival of less than 50%. If you ask cancer patients what they want from chemotherapy, they're going to tell you the following. You want the treatments to work. So what's work? Well, certainly more than that. You want to see benefit. How about 50%, 60%, 70%? And you don't want to see a 1-year survival of 50%. How about a 2-year, 3-year survival of 50%? So you want treatment to work, you want a better survival, and you want a much better quality of life, which means fewer side effects. That's what patients want. I think oncologists, before they sit down and write a protocol, they should speak to 100 patients and ask the patients what they want. And if that's what they want, then the oncologist should ask, does FOLFIRINOX or Gemabraxane or Gemabraxane Platinum deliver what they want? And for me, it's no. Most of my patients come from other practices where patients have been previously treated and they can't tolerate the side effects. And oncologists are so rigid about the dose, they'll continue the doses that are intolerable till the patient actually leaves their practice. Next slide. So How can we change what I've just talked about? What we really need is a way of accurately selecting effective drugs for each and every patient. We need to use lower doses, so we'll have fewer side effects, less adverse reaction, and hopefully no toxicity. So the question is, why can't we give chemotherapy without side effects? And the answer is you can. The side effects are directly related to the dose. You lower the doses enough, and you'll have fewer side effects. The truth, lowering the doses will not diminish efficacy. And we need a rational design of treatment schedules. In this case, timing is everything. In my earlier years, when I had a laboratory, I looked at drug-drug combinations. And if you had two drugs and gave them at the same time, they had the potential of being antagonistic. If you change the timing of administration, you can make them synergistic. One good example is this, is we had a trial in colon cancer where we gave 5-FU, calcium leucovorin, and methotrexate all on the same day, and the overall response was 10%. When we gave the methotrexate on day 1 and 5-FU and leucovorin on day 2, the overall response rate was 30% using the same drugs and the same dose, but on a rational schedule based on what was going on biochemically. In addition to, we see higher response rates, we saw a statistical significance in survival. And the last 4 and 5 is strictly me speaking, not the Hirschberg Foundation. Stop the use of guidelines. They don't work for the majority of patients, period. And they prevent progress. And those patients that are treated with the guidelines, most of them get pretty sick. As I said before, 30% end up in the hospital, 50 to 100% get growth factors. And the truth, these oncologists that say they're using the guidelines, they're not using the guidelines. The guidelines are, what are the drugs, what's the dose, and what's the schedule? If you go to the Mayo Clinic and they tell you they're going to give you FOLFIRINOX, they will eliminate irinotecan day 1 to see how you tolerate. Well, that's not the guidelines. By the second cycle, more than 50% of the patients going to university-based hospitals have already had their doses adjusted. So if you're not getting the right doses on the right schedule, you're not getting the guidelines. Adhering to guidelines, okay, basically prevents alternative treatment options and therefore prevents progress. So what we really need is pick better drugs, use them safely, and look at the biochemistry and the pharmacology of each drug and design a more rational treatment schedule. Next slide. Next slide. Okay. So in order to pick effective drugs, you need an accurate and reliable in vitro predictive assay, and it should be available for all patients. The reason is, if you can do an in vitro assay that would tell you the best drugs to use, each patient would have personalized care. You would avoid using ineffective drugs. You'd stop wasting time using drugs that don't work, and you'd save a hell of a lot of money. If I gave such an assay to an insurance company and showed them that if patients were taking the assay and being put on better drugs, so you're not using ineffective drugs, i.e. the insurance company's not paying for drugs that do not work, there'd be a big shift in how patients get treated. So we need an accurate way of picking the right drugs for each individual patient to truly personalize medicine. And then when you have the right drugs, you need to give them safely. So I emphasize safety first and then accurate drugs at the same time. But we should be able to treat cancer patients without toxicity. Next slide. Okay, so there is such an assay. I've been sending specimens to Adara Labs. It's a blood-borne assay, basically a liquid biopsy. In 5 cc's of blood, they can extract free circulating cancer cells. And from these cancer cells, they can extract the RNA from circulating tumor cells, and they can do a quantitative PCR assay on the RNA from 86 genes, okay? And then they have a data bank showing the expression of these different genes compared to hundreds of other specimens, and can accurately predict which of the following FDA approved drugs would be most beneficial to treat a given patient. And the drugs that they test are gemcitabine, Abraxane, 5-FU, oxaliplatinum, irinotecan, mitomycin C, and cisplatin. These are all FDA approved, and they are all used to treat patients with pancreatic cancer. Next slide. When we decide on the drugs, we give extremely low doses, and here are some of the schedules. Gemcitabine, 800 milligrams. These are total doses. The standard dose for gem is 1,000 milligrams per meter squared, or closer to 1,800 milligrams. We give it weekly for 3 weeks. The Abraxane is somewhere between 70 and 100 milligrams weekly for 3 weeks. 5-FU is a continuous infusion at 200 to 300 milligrams a day over 14 days. Why is this better than 48 hours? If you give low concentrations of 5-FU, you are depressing the bone marrow for 14 days. During those 14 days, you prevent the bone marrow from releasing those endothelial precursors. And as a result, when given this way, it's anti-angiogenic. You can substitute the 5-FU for capecitabine and use, again, a very low dose, either 500 milligrams twice a day for 14 days, or 500 milligrams in the morning and 1,000 milligrams at night for 14 days. You will not necessarily have the cytotoxic effect from the 5-FU, but you will have the anti-angiogenic effect from the 5-FU. The rest of the drugs, oxaliplatinum, irinotecan, mitomycin C, and cisplatin. A couple of words about mitomycin C. This is by far one of the best drugs for pancreatic cancer that oncologists refuse to use for 2 reasons. One, it's a very active drug. And in multiple trials in the old literature, there is definite activity. The second reason is that in those patients that have a BRCA mutation, whether germline mutation or somatic mutation, mitomycin C is actually better than cisplatin in inducing a response. In the study by Pancreatic Cancer Action Network, where they were the Know Your Cancer study or Know Your Tumor study, where they biopsied and got tissues from 1,000 patients, sequenced the genes, and found a certain percentage, a small percentage, 5%, had BRCA mutations. If they got cisplatin and were BRCA mutated, survival was doubled, showing that cisplatin is a very important drug with activity in BRCA mutated patients. The same is true for mitomycin C, but even better. In fact, when this was first studied by Myriad Labs in a paper by Michael Goggins and published in 2003, the patients that were BRCA mutated were high responders to mitomycin C, and the mitomycin C was actually, or a response to mitomycin C, was actually picking out the BRCA mutated patients. So these two drugs are very active, and yes, yet oncology, first of all, mitomycin C isn't part of standard of care because oncologists are afraid to use it, and the people that write things don't read the old literature. And mitomycin C is a drug that's off patent, so you don't have a drug company bribing the people writing the guidelines. So it's not used. It's a very active drug and should be used. Anyway, these are the drugs that we have used in patients that have undergone the in vitro chemosensitivity assay by Adara Labs. Next slide. So here's an example of the last patient, well, really not the last patient, of a patient whose specimen was reported on the 28th of May. And every time you see a plus mark for oxaliplatin, Abraxane, and gemcitabine, that would be an active drug. So it's simple. You take those three drugs. We already know Abraxane is standard of care, and now you add oxaliplatin at low doses, and you use the doses that I referred to in the previous slide. So this patient would tolerate gemcitabine, let's say 800 milligrams, Abraxane 80 milligrams, oxaliplatin 70 milligrams. You just give it weekly for 3 consecutive weeks and a 1-week rest. Now, what's the advantage of doing it this way? Well, let's say you gave it on week 1 and the patient tolerated the treatment. Fabulous. Comes back for week 2. He's feeling fine. You give him the second dose. On week 3, he's had some toxicity, such that you can either eliminate the entire treatment till the patient recovers, and it would be a shorter recovery, or you can eliminate one of the drugs and just give 2 of the drugs, depending on the side effect. Compare that to using 3 times the dose and giving it all on the first week. Once it's in, and you can't get it back, and you're going to see side effects. If you give it gradually, you have fewer side effects, and the bone marrow, more importantly, tolerates it much better. So over a protracted period of time, the duration on therapy, instead of being 4 months, will be closer to 8 or 10 months. Okay. What's also interesting, if you ran this assay on an individual patient, let's say every 3 to 4 months, right now it's telling you that this cancer is not going to be sensitive to irinotecan. Over time, the cancer is going to mutate in such a way to develop resistance to oxalate, Abraxane, or gemcitabine, and will become sensitive to irinotecan. So what most oncologists think, well, we tried FOLFIRI and that doesn't work. Okay, so that means the patient will never be sensitive, or the cancer, to irinotecan. That is not true. What happens is the cancers are constantly mutating and they are developing resistance to certain drugs. As a result, will develop sensitivity to other drugs that they weren't initially sensitive to. Next slide. So one of the things we measured when we, we studied, this is a retrospective study of 45 patients. One of the things we studied is the duration of time on therapy, okay? If you only had none, 1 or 2 drugs that matched the assay that you were using to treat the patient, median time on therapy was 4 months. However, if you had 3, 4, 5, or 6 drugs that matched the chemosensitivity assay, the median time on therapy was 10 months. It doesn't mean that's the median time of 10 months on total therapy. It means on first line therapy. Patient developed resistance, you can repeat the chemosensitivity assay and learn which drugs after 10 months, okay, are now more active and use those drugs. Next slide. Okay, so using this in vitro chemosensitivity assay, we looked at the number of drugs that were matched, meaning identified as positive on the assay, and we actually used them to treat the patient. If you only had 1 drug, that happened 5 times, that we used based on the assay and treated the patient, in survival of 11 months, which equaled FOLFIRINOX, but without any side effects or minimal side effects. As we go to 2, 3, 4, 5, and 6 drugs, you can see that the survival in months keeps on increasing to the point if you go back to the patient on the previous slide where he had 3 matches and we used those drugs to treat 19 patients that had 3 matches. The median survival in months was 26 months. And basically, these are all going to be in the same range, 30 months or more. So if you use the assay, you have a lot of drugs used in the patient that match the assay. We're now talking an advanced disease, a median survival of 30 months. This is 3 times greater than what we can see in FOLFIRINOX with fewer side effects. Next slide. So in this study, we did 45 patients, and this shows the median time on frontline therapy. And you can see when 3 drugs were matched, 3 drugs from the assay used in the patient, we had a median time on therapy of 10 months, statistically significantly longer than 2 drugs or less. Next slide. Here's survival. When the blue line is 0, 1, or 2, and drugs that match the assay versus 3. Okay, if you look at the, that's right. Oh, okay. So we had a 3-year survival of 60%. Yeah, a 3-year survival of almost 60%. If you looked at all of the patients, regardless of how many drugs matched, the 2-year survival is more than 50%. Which is quite dramatic. I'm not sure this is the right number. This could be a typo. Let's stop it here. I'm not sure this is 36 months. It could be 26 months. Let's not look at this column. But at 2 years, you can see that if you had 3 or more matches, you have almost a 75% chance of living 2 years, which is dramatic compared to anything else reported in the world's literature. Now, it's true, it's only 45 patients. But the two things that are important is when we gave the drugs at low doses. So we weren't giving, super aggressive therapy. We were just giving the right therapy at doses that were well tolerated. Next slide. Here's some of the adverse reactions, the grade 3 and 4 toxicities. Most were hematologic, anemia, neutropenia, and thrombocytopenia. So the majority of patients did not have severe neutropenia. The result, we didn't use growth factors like other trials that use it in 50% or more. We don't have the exact tabulation, but I would say it's 20% or less. So we're saving all that money on growth factors, and we had very few hospitalizations from side effects. Next slide, please. So in conclusion, this in vitro chemosensitivity assay was successful. It helped us pick effective drugs, and it resulted in a significant benefit in overall survival when we compared it to historical controls, whether that be FOLFIRINOX, Gemabraxane, and a platinum. When combined with metronomic dosing and schedules, the treatment was safe, it was effective, and well tolerated. Next slide. So what do we really need? We need higher response rates and overall survival for everyone of greater than 2 years. We need not lower toxicity, no toxicity. There's no reason why you can't give chemotherapy without toxic side effects. We need to be able to treat all patients. So there are 2 groups of patients that are not being adequately treated. Older patients. In general, patients over 75 do not get effective treatment for pancreatic cancer. And patients that have a poor performance status with a variety of other medical issues that offer comorbidities, the result being oncologists are afraid to treat them because the treatment's too toxic. We need treatment that does not use growth factors, avoid hospitalizations, and result in less expensive treatment. And I would say if you combine lower toxicity, you'll get an improved quality of life. So I would say first and foremost, this should be no toxicity, better quality of life, and then higher response rates with improved 2-year survival. And now I'm happy to have questions and have discussion.
Thank you, Dr. Isacoff. We had some questions come in before your presentation through registration. Let's get to those first and then head into the chat area and answer some general questions. Our friend Steve Merlin has a comment. Patients who undergo Whipple or distal pancreatectomy often hear, "We got it all," interpreting it as they are cured, don't need adjuvant therapy, or want to take only the bare minimum chemotherapy. Oncologists need to explain minimal residual disease. Your thoughts?
The advice that oncologists should give patients regarding adjuvant therapy relies on the pathology. There are certain pathologies where you may not require aggressive post-operative chemotherapy. I would say that's in the minority, maybe 20% or less. In the majority of patients, you need to look at whether or not the tumor is well differentiated or poorly differentiated. You need to see whether or not there is lymphovascular invasion or perineural invasion. All of these correlate with overall prognosis and probability of recurrence. And most importantly, you need to look at the nodes. So if you have a very small tumor and no lymphovascular invasion and no perineural invasion, and the nodes are negative, you may get away with milder chemotherapy. That's on one hand. On the other hand, one of the things we can, so my feeling is that for the majority of patients, you do need post-operative treatment, and the post-operative treatment is not going to be of a benign kind, but you have to go by the pathology. One resource that I think is underutilized is liquid biopsies, which is the following. Just as we can trap circulating cancer cells, we can trap free circulating fragment DNA. We can sequence the genes and see if in those genes we can find pathologic mutations. If there are a significant number of pathologic mutations that are freely circulating, depending on what they are, will dictate how much adjuvant chemotherapy the patient will need, especially if you did liquid biopsies and you did them every 2 to 3 months and the number of pathologic mutations were increasing, for sure you need adjuvant therapy. So the first and foremost would be looking at the pathology, looking at prognostic parameters based on the pathology, and then monitoring the patient either before, during, or certainly after adjuvant therapy to see if there are circulating fragments of free DNA with pathologic mutations.
And Jane asks about the connection between BRCA2 and pancreatic cancer.
Well, BRCA2 is part of a category of genes that are referred to as DNA repair genes. And as a result, the patients BRCA mutated have a higher statistical probability of developing pancreatic cancer. So there is a cause and effect relationship. What happens is our DNA is replicating millions of times a minute, and it's constantly making mistakes. There are a set of genes that have to recognize mistakes and repair them. If these repair mechanisms are not intact, the patient has a higher probability of getting a cancer. And some of these BRCA mutated carriers have a higher probability of pancreatic cancer. I'm not sure I answered the question, but what was the question?
Question about connection between BRCA2 and pancreatic cancer.
If it's a germline mutation that the patient inherited, okay, there's a definite correlation between the risk of developing cancer and the carrier of the BRCA mutation. Yes, and those patients should be very closely monitored.
And Charles asks, I'm currently on a 3 to 4 week interval for chemotherapy, and that works much better for me in terms of how I feel and quality of life. My CA19-9 is approximately 50 and scans are okay too. What is your opinion on the sustainability of this approach?
I probably not feel comfortable getting into individual cases. My own bias is I like to give chemotherapy frequently, and if quality of life is of concern, which it should be, I would lower the doses. But if the CA19-9 is in a good range and has been stable, I think that would be the best parameter to monitor, even better than scans. And if the 19-9 is staying within a narrow range, and if you want to use the word stable, I think I would look at the 19-9 every 6 or 8 weeks. If it's staying in a good range, stick with the regimen you're on.
George says, how do you treat the patient with myeloma on the pancreas? Do you treat patients with pancreas cancer or different with myeloma on the pancreas?
You treat the patient, his underlying disease is multiple myeloma, and should be treated with those drugs that treat multiple myeloma.
How was it determined that 12 cycles of modified FOLFIRINOX was an ideal number of cycles, with 8 being the minimum? Was it first through response in animal models or in a phase 1 trial to start at that number? Or was it through multiple trials of cohorts to select those numbers?
It's a good question. There were no animal models. The way FOLFIRINOX got to be FOLFIRINOX was more or less an accident. It was really designed and developed to treat patients with colorectal cancer. After the United States developed, or Eli Lilly, gemcitabine, and we were so encouraged by the early results, the Europeans tried gemcitabine and were disappointed. So they wanted to design a study, the French, where they used a non-gemcitabine containing combination and compared to gemcitabine. And there was this regimen FOLFIRINOX that was being used for colon cancer, so they picked that. So it had nothing to do with animal models. It was designed to actually prove that you can use 3 drugs that didn't contain gemcitabine, and it would be better than gemcitabine alone. With regard to the number of cycles, that's just 10 guys sitting around a table and let's pick a number. It's based on nothing. The reality is that if you give FOLFIRINOX, you're not going to tolerate 8 cycles, 9 cycles, or even 10 cycles. So the number of cycles is based on what you can tolerate. And most of the time, by 3 or 4 cycles, the doses are being adjusted to what the patient could tolerate. And as long as there's an awareness of active disease, you should continue whatever treatment for as long as possible, as long as the patient is tolerating it.
Is the Adara Labs chemosensitivity assay similar to 3D organoid assays for chemo agent sensitivity resistance determinations?
No, who asked that question?
Steve Merlin.
Steve, last name?
Merlin?
Okay, so the question, what's an organoid? It's a biopsy of a patient's tumor growing basically as a three-dimensional mass in tissue culture. And the first question is, when you biopsy something, what's actually growing in the organoid? The second question is, how often, when you biopsy for an organoid, can you actually make an organoid? And then then you have to have offspring from the organoids to make many organoids. The idea being is to test drugs in each of these organoids to see which drugs would cause the greatest degree of growth inhibition of a patient's individual cancer. There are two problems with organoids as I see it. One, it takes a long time to grow enough organoids to test drugs, probably 6 or 8 weeks. So if you did the biopsy on June 1st, you're not going to have an organoid, assuming you make an organoid, until September 1st. By September 1st, the tumor that you biopsy is different. It's already mutated and it's already been exposed to different drugs. And it's expensive. So right now, for me, I would view it as a research tool for scientists to study drug-drug combinations on cancer tissues growing culture. But I don't think it's going to be an effective way to treat large numbers of patients because it'll be one, too expensive, two, too long to have enough organoids from that patient growing to test enough drugs.
Thank you, Dr. Izakov. We have a few more questions in the chat.
Go ahead.
Does Dr. Isacoff do phone consultations with other oncologists, or how could we tap into his expertise and bring this info to our current oncologists?
Have the oncologist call, be happy to talk.
Okay. Is it possible?
But the oncologist has to be willing to say that some of the recommendations under the heading of standard of care are not ideal. What I mean is that they are too toxic and you have to be able to give non-toxic. I have patients I've been treating since 2006 and they're still on treatment. And the reason is because I give them doses that they can tolerate over a long period of time and continue to work. So the idea is that if you want to have a conversation, you have to have a conversation that first centers about using treatments that are safe. And being willing to use treatments that are not in, none of the treatments I use are in the guidelines. But the patients that I treat are willing to be treated with something other than standard of care, because they want to, if you will, beat the odds. But I'm happy to talk to any oncologist that's willing to have an honest conversation.
Great. Two more questions. Is it possible to perform liquid biopsies by using mass spectrum?
No. A liquid biopsy is, well, I can't answer that. But basically, a liquid biopsy, as I think of it, is taking a fragment of DNA and sequencing genes. And I don't think mass spec is going to sequence a gene. So you need a gene sequencer. And the purpose of a liquid biopsy is one, finding fragments of free circulating DNA, and then sequencing the genes to find, are there genes that are mutated or not? And if there are no mutations, that's good. If there are mutations, are those mutations driving the cancer, or are those mutations something for which we have drugs? I think mass spec is going to help us with gene sequencing.
Thank you. Do insurance companies generally push back on covering treatments that are non-standard of care?
Yes. Every day. And I mean, you know, to me, they're breaking the law. And the reason I say that is that in the state of California, so I can speak for California, what an insurance company, if they deny treatment, they will use the words, this drug is not of medical necessity. And so you get into a discussion as to what is medical necessity. And the law passed in the state of California in 2004 that will define medical necessity. And as it relates to cancer, if you have a life-threatening disease, a medical oncologist can prescribe any drug for that patient that's FDA approved, which means if it was approved for lung cancer or colon cancer, but not pancreatic cancer, and I want to use it in pancreatic cancer, so I'm using it in what we call off-label, I'm entitled to do that. But insurance companies don't want to pay for it, so they deny paying for it by using the words not of medical necessity. And I don't want to get into the legal aspects of it, but I would guess if they would take it to court, they would lose. So insurance companies will deny those drugs that are not on their list as defined by the guidelines. So if I wanted to use cytosine or rabinoside, they would say no. I just had a lady that was mutated in a JAK1 inhibitor. I wanted to give her Jakafi, and she was denied. But what, you know, we're going to try to get the drug, but it happens every day.
Aggie?
The thing that's confusing and frustrating is, on one hand, all of the, in my opinion, very intelligent people say that the cancer is mutated in every patient in its own way, and therefore every cancer is different from every other cancer. And even metastases are different from the primary. And you can make a case that even a lung met should be treated different than a liver metastasis, which is different than the primary itself. So if that's true in an individual patient, when you have patient A compared to patient B, they're completely different. And yet the guidelines tell us to treat everyone the same. So it's an irrational conversation. If every cancer is different, Every cancer should be treated differently, and every treatment should be tailored to that patient. So how can we use FOLFIRINOX, Gemabraxane on every patient? It is, from a scientific point of view, completely irrational. That's why we're going nowhere.
Okay. May I start to close the meeting? We're a little bit over time. And what I want to say to you,
Overtime, you're paying me to go overtime. Before the meeting, said, I'll pay you time and a half to go overtime.
Dr. Isacoff, your last presentation had 75,000 views. This one is going to have 50,000 or 100,000 views.
Okay.
So it was honest and realistic, and we appreciate it. But now, I don't know if you can see this. Can you see that at all? Am I?
No.
No? It's a letter it's a handwritten letter to you in July 4th, 1997.
Oh,
As you encouraged me to start the foundation, and along with Dr. Reaver, and if not for you, not for our friendship, I would not be the first foundation to happen in the United States, and I wouldn't be here with you right now. And I think one of the lines that I highlighted is, without your guidance, I cannot take the next step. So I thank you for all of your patience, all of your time, and of course our friendship, which is very special to me and us.
well, thank you. And the only the people that come to your party every year know truly how hard you work all year round. And I don't know of anyone in any foundation working as hard as you, not only with your book, first and foremost for all the patients, but also with all of the scientists that you want to nurture and push and do more. And so a big round of applause for you. And the pancreatic cancer family is a lot better off because of the Hirschbergs.
Thank you.
You're
We all know that you're retiring, and your next phase is really what you love, is the research part. So I know that the foundation needs a list of doctors that are thinking out of the box, and so that we can forward that to our patients.
Well, there are a couple in LA that are absolutely superb. We'll talk about it.
Okay, thank you. Thank you, everyone.
Keep doing this. Keep doing it.
Thank
Maybe
you.
more frequently. Thanks, Aggie.
Thank you.
Have
so
a great weekend.
Thank you. Thank you, everybody, for joining us. I wish I could see everybody. Can you, Alyssa, can you make Dr. Isacoff smaller and see the whole group, or no? No?
Yes. It
Yes.
should have changed on your screen.
Okay. I don't see everyone.
Well, we've got 3 pages of people here, so.
Okay, well, thank you so much, everyone. And
Thank you, Aggie.
Thank you.
Be
It was
well.
Wonderful.
Be well.
thank you.
Thank you.
Thank you all.
Bye.
Thank you.